to one and all. Today's topic is thoracic injuries. Now come to the anatomy. Bony anatomy. Thorax, it has anteriorly having sternum, lateral ribs were present, and posteriorly vertebrae was present. For abdomen, posterior vertebrae and lateral ribs are present. Muscular anatomy. Muscles of inspiration are diaphragm and intercostals. Muscles of expiration are abdominal muscles like rectus abdominis, internal and external oblique, transverse abdominis. Respiratory tract anatomy. Lungs. Left lung has 2 lobes, right lung has 3 lobes. Trachea. Trachea is divided into bronchi. And pleural linings are parietal lining which lines the cavity and visceral lining which lines the lungs. The pleural linings creates a potential space in lung. Cardiovascular anatomy. Heart has 2 arteries and 2 ventricles. Vascular structures are present like aorta, inferior superior vena cava, pulmonary arteries and pulmonary veins. Evaluation. History. First we have to see the onset of symptoms, like if musculoskeletal, usually there will be rapid in onset. If organ related, they may have quick or slow onset depending upon structure and amount or rate of bleeding. Symptoms and chief complaints will be present like dyspnea, abdominal pain, nausea, vomiting, dizziness, hematuria, blood in stool, etc. Medical history, like any prior thoracic or abdominal injuries, we have to ask. And mechanism of injury or etiology. Almost all etiology associated with direct trauma to thorax were like another competitor, equipment, ground, or increased incidence with trauma to unprotected areas. Location of pain, you must know the anatomy. Inspection or observation. Posture, often lean toward painful area for splinting. Breathing pattern, we have to check the rate, depth and quality of the breaths. And capillary refill, we have to done but fingers for cursory vascular evaluation. And we have to check for muscle tone, tension due to spasm or any internal bleeding. And discoloration, typically not visible but abrasions etc. indicative of potential underlying trauma. Vomiting, coffee grounds if blood in it. Hematuria, if visible, significant for genitourinary conditions, may need urine analysis for ultimate determination. Injuries. Thoracic injuries, bony injuries like rib fracture, most common to anterior or lateral aspect of 5th to 9th ribs. Flail chest, 4 or more ribs fractured in 2 or more places. Sternum fracture, potential for significant injury if posterior displacement is occurred. Thoracic injuries like pneumothorax, accumulation of air in the pleural cavity that affects ability of lung to expand, causes decreased oxygen, hypoxia and respiratory distress. Symptoms will be present like dyspnea, pain with respirations, guarding or splinting of affected areas, possible cyanosis will be there. Decreased or absent breath sounds on auscultation of affected lung can be felt. Hemothorax, accumulation of the blood in the pleural cavity is called hemothorax. Bleeding from lacerated lung or rupture of blood vessel within the thoracic cavity will causes the bleed. Maybe also from penetrating injury. Often occurs simultaneously with pneumothorax. Management, immediate chest decompression, lateral thoracostomy, insertion of chest drain. Bilateral may be necessary if you get bilateral tension. Needle decompression called thoracocentesis should be considered a last resort. 14 gauge cannula will be kept at second intercostal space in midclavicular line. It is an open procedure, blunt dissection at 5th intercostal space 1 cm anterior to mid-axillary line. Complications related due to this condition are like hematoma, intercostal neurovascular injury, thoracic and abdominal visceral injury, infection, etc. Also maybe tube malposition, maybe the complication of lateral thoracostomy. Like this we will perform the thoracostomy. Now emphysema thoracosis, accumulation of pus in the pleural cavity. Incidence is 5 to 10% of hospitalized patient with Parapneumatic effusion. Etiology: contamination from a source contagious to the pleural space. 50 to 60% are lung, mediastinum, deep cervical, chest wall, and spine. Subphrenic: direct inoculation of the pleural space. 30 to 40%. Minor thoracic interventions, postoperative infections, penetrating chest injuries, and hematogenous infection of the pleural space from a distant site is less than 15%. Pathology: there are three stages. In stage 1, exudative phase, which is called acute phase; stage 2, fibrinopurulent phase, which is called transitional phase; and stage 3, organizing phase, which is called chronic phase. In exudative phase has relatively low LDH, normal glucose, and normal pH. But in fibropurulent stage, increased fibrin deposition causes cellular debris and blood cells formation of fibrinous membranes producing loculations. In organizing or chronic phase, fibroblasts grow into fibrin sheet coating the visceral and parietal pleura, causes pleural peel causing entrapment of the lung. Clinical stages: acute within the first 2 weeks of onset, chronic after 2 weeks or with the formation of thick peel or loculations. Complications: these are more likely to develop during the chronic phase. The complications are like pulmonary fibrosis, contraction of the chest wall, spontaneous drainage through the skin called as empyema, necessitatis, spontaneous drainage through the bronchus called bronchopleural fistula, others like osteomyelitis of rib and spine, pericarditis, mediastinal abscess, and subphrenic abscess. Suspicion: acute respiratory illness with associated pleural effusion. The most common initial manifestations like dyspnea in 82%, fever 81%, cough 70% and chest pain will be present in 67% of patients. Tachycardia, malaise, anorexia, and weight loss very acutely or develop insidiously over weeks. On physical examination, we will see the diminished mobility of the involved hemothorax, decreased breath sounds, and dullness on percussion. Diagnosis: we have to collect the pus obtained from on thoracosynthesis. Glucose concentration less than 40 mg per dl will present. LDH greater than 3 times the upper limit of normal and pH less than 7.2. Chest X-ray, posterior, anterior, and lateral chest X-ray have to be done. 150 to 200 ml needed to blunt costophrenic angle. On ultrasonography, localize small amount of fluid and loculation and identify pleural field. On CT scan, you can see differentiating empyema, lung abscess, and subdiaphragmatic fluid. Management: medical management. Non-interventional therapy often contraindicated. Thoracosynthesis and cultural sensitivity based antibiotic therapy generally successful for stage 1, but it is not considered for stage 2 and stage 3. Surgical: tube thoracostomy. Connected to negative suction of 20 mm Hg, the tube withdrawn slowly several weeks until removed. Insertion of pigtail catheter with the administration of fibrinolytics such as streptokinase or urokinase until the pleural space is cleared. Surgery is contraindicated. Thoracoscopy, the next therapeutic option after fibrinolysis. Advantages on this are visualization. Determine if complete drainage of all empyema, disruption of all adhesions and loculations. Decortication of lung and space filling by muscle transplants, space collapse. Decortication via thoracotomy should be performed when third stage is suggested by CT scan. We have to remove all purulent fluid, fibrinous debris, thickened parietal pleura from the pleural space, and resection of visceral pleural peel. Rib resection, drainage, and open thoracic window. Resection of a short segment rib over the most dependent part. The opening and deloculation of the space. Insertion of a large multi-fenestrated tube into the cavity. If the visceral pleura is thin and stretchable, space obliteration will be present. A more permanent creation of an open window thoracostomy. This is particularly useful for patients in whom long-term drainage may be required. Broncholeural fistulas. They aggravate the course of empyema and indicates persistent contamination of the pleural space. Difficulties in the re-expansion of lung and possible aspiration will be present in the remaining lung. Coughing up of serosangous fluid or pus causes fever, malaise, and chest X-ray shows small space may be enlarged or a newly formed air fluid lowering or sudden disappearance of a pleural effusion or a mediastinal shift towards the contralateral side will be present. A drop of at least 2 intercostal space is considered significant. The diagnosis of a bronchoalveolar fistula is usually made by bronchoscopy or by observing persistent air leak through it. Conservative treatment like suction drainage. In suction drainage, fibrin sealants applied through the rigid bronchoscope. The flexible fiber optic bronchoscope will be taken. Reclosure of the bronchus will be done, and reamputation of the stump will be done. Additional sealing of pulmonary sutures or additional resection may be advisable. Secondary failures because of local pressure by purulent collection. In this situation, drainage should be done initially, followed by definitive management, which consists of bronchial reclosure, muzzle flap, or thoracoplasty. Thank you.